Welcome to Good Tech, Compassionate Healthcare, an AMS healthcare podcast that explores the convergence of technology and compassion in healthcare. We host conversations between leading researchers, scientists, and healthcare providers as they confront the challenges threatening our current and future healthcare system, especially in the face of the pandemic. We see an incredible opportunity for digital health to innovate medicine and clinical care, healthcare education, home care, and beyond. That said, we hope to foster an open-ended discussion about how to integrate technology into the healthcare system in a way that enhances and doesn't diminish compassionate care. Ultimately, improving the experience of patients, caregivers, and healthcare providers alike. If there was ever a time to uphold compassion as the bedrock and guiding principle of healthcare, it's now. Join us now to explore Good Tech, Compassionate Healthcare, brought to you by AMS Healthcare. In this conversation, Alika Lafontaine, an indigenous physician from Northern Alberta and the president-elect nominee of the Canadian Medical Association, and Brian D. Hodges, Chief Medical Officer and EVP for Education at the University Health Network, discuss building virtual relationships.
So I'm Alika Lafontaine. I'm an indigenous physician from Northern Alberta, having this conversation about virtual care and the role of technology in healthcare. I find very exciting because in my own practice, I've seen big changes that have been accelerated through the pandemic, some of which have been very good at advancing the cause of patient-centered care, and some that have not. And I'm really excited about delving into this deeper with you, Brian.
I'm Brian Hodges. I'm the Chief Medical Officer and EVP for Education at University Health Network. And my background is psychiatry. During the pandemic, I've seen similarly an extraordinary shift in what we're doing. My own practice went from face-to-face to virtual overnight and has stayed almost entirely virtual since. And in my Chief Medical Officer role, trying to support a whole lot of different kinds of specialists grappling with radically different practice environments. So yeah, I share your enthusiasm to talk about the pluses and minuses about this, and a technology that we didn't have much choice about adopting. It just happened to us. Alika, I'd love to hear about how you're using virtual yourself in your own practice now.
I think for physicians in Alberta, the role of virtual care and technology has been different than other parts of the country. We had planned to adopt a provincial electronic medical record years before the pandemic hit. And we proceeded with that adoption mid-pandemic. And Connect Care was hard to get onto, to be honest. Anytime we have any changes in our workflow, it ends up being a challenge. And I know that we're only partway through the adoption across the province. People are very concerned about how it'll change their workflows. And to be honest, it's frustrating. We go and train for 10 plus years to do the jobs that we do. We get used to the ways that we do them. And then something comes along and provides a whole different way of providing care. I have found that as we've adopted the provincial EMR, there's definitely been benefits. I think you're getting more standardization as far as input of information, using different macros that arrange what information you need to put in, I think is helpful, especially for those of us who have different ways of kind of approaching data input. There's very easy ways of sharing information with patients, which I think is absolutely fantastic. That by itself is worth adoption. The fact that I can share my electronic medical records as I provide an anesthetic directly with patients. And I think that will be very, very empowering for the patients that I care for. But then there's other things that I've noticed too. I think in design, you have a mix of persons who are clinicians who understand the way that workflows day to day. And then there's those who I think have worked on the software that are a bit removed from how things actually work. And the reality is things don't work the same way everywhere. And I found at my own institution, which is a community hospital, that provides the majority of care for persons in the north. We're kind of the last stop before you head to an urban center like Edmonton or Calgary. That there's been a shifting of burden, especially when it comes to data input, from those within quality improvement and all these different programs that we have that help to provide the raw data for the metrics that we use to guide the healthcare system to physicians themselves. And that at times can be very overwhelming. It definitely adds a lot more to the work that we do. And in the midst of the pandemic, when our bandwidth is already maxed out, it's difficult to find the time. We are finding the time because we have to, because that's the way that, record keeping works now. I think that that's probably one of the main sources of stress for adopting, this new way of doing things.
I'm interested in the Alberta model. It's been cited across Canada as a very centralized model and the adoption of a smaller number of technologies. I'm in Ontario, where we have many different systems. Our challenge is a little different in terms of connecting all of those multiple systems together. And I think we're a little earlier in choosing which ones. I'm interested to hear a bit about your experience of those facilitator technologies. I think later we'll speak about virtual connectivity with patients, but I thought we could jump off first with your point about patient access. Atul Gawande is famous for an article called Why Doctors Hate Their Computers. And essentially, it's a discussion about what you just mentioned, which is the downloading of all the extra work. In the United States, they've adopted scribes, for example, to help. And I'm also aware of people moving in the direction of voice dictation and even artificial intelligence to try to streamline the interface for the clinician to try to make it a little easier to input data. Have you had experience with any of those, with scribes or with voice dictation or any of the technologies that are meant to make it a little easier interface?
Mm-hmm. Dragon Dictation is integrated within Connect Care, so you can actually connect with your phone. I think that does provide a pathway for persons to voice dictate that's very smooth, right? Once you kind of figure out how to do it, it's actually a really, really great system. And it autocorrects and, dictates in real time. So you can edit your notes directly and it is quite straightforward and easy. The mentioning of Atul Gawande is interesting because he was supposed to head up that collaborative think tank that Amazon and Warren Buffett and I forget the other groups that had come together to kind of create a new path to healthcare had organized a few years ago. And that was actually disbanded, right? They found that it wasn't achieving the effectiveness that they wanted. And it's interesting that these problems are so complex that even if you take someone like Atul Gawande, who is probably recognized as one of the foremost thinkers in a lot of the areas that we're trying to change contemporaneously in medicine, still struggles, even with the resources of, a company like Amazon or Berkshire Hathaway or, all these other groups that really want to make change for different reasons. And I think when you're talking about these accessory technologies, there's a disconnection, I think, between the way that we approach technology adoption within healthcare. We often talk about centralization or decentralization as these catch-all blanket statements. You have to have a system one way, you have to have a system other ways. I think the third way that you can organize a system is distributed systems. And all three of those are very different, right? And depending on what you're doing within healthcare, the benefit of adopting any one of those types of systems is different. For centralized systems, those work best in an environment like COVID, right? If we didn't have centralized systems, it would be impossible for us to make the massive change that we needed to in order to respond to this system-wide event that confronted pretty much the whole world at around the same time. Centralized systems, on the other hand, don't work really well when it comes to recruitment in an area that's a lot smaller related to like the voice that they have at the table. You take a clinic in far northern Alberta and you have them advocate for their needs at a table where Edmonton, Calgary, Lethbridge, Grand Prairie, like all these larger institutions are asking for more resources. It's tough for these small communities to actually advocate for what they need. And I think this is true for technology adoption as well, especially those accessory technologies that you mentioned, including scribes. I think that technology, when adopted well, it gets incorporated seamlessly into your workflow and actually makes it easier. Just think through calendars, for example. Calendar systems that we use nowadays, they automatically grab stuff from your email and pop in your appointments. We don't have to download those files anymore and manually put them in. That saves me endless hours of effort in organizing meetings now. And I think when you look at technology adoption and the need to hire someone in addition to what you're doing or adopt another accessory technology just to survive with the new technology workflow that you've adopted, I think you've missed the point of what technology is supposed to do. It's supposed to make it easier for someone, right? And if it makes it easier for patients and it makes it harder for physicians or their frontline healthcare workers, I mean, that's a trade-off that you can talk about and find out where that works. But if it's making it harder for everyone, then maybe the technology that you're adopting isn't the right kind of technology, or maybe some thought needs to be brought into how are you bringing it in, or how are you selecting technology, or other things like that. And, I've had the experience of building software now for a couple of years with co-founders of a tech company that I'm a part of. And eventually you build software to the point that it is actually very difficult to go back and change your underlying foundational premise of how you design. I think when you look at these larger systems that are used, particularly for EMRs across North America and elsewhere, these were built in the 70s. They've been around for decades. The ways that they go about doing things are really built on older ways of how workflows work. And I think that's something we're going to have to reconcile now that we're adopting it at the rate that we are. And I think it just goes back to a general principle of good ideas. Good ideas are always great when they're used by the people that generated those ideas. But once you take those ideas into the wild and people start to adopt them at a broader scale, you start to realize that what you thought was great is really terrible for someone else. And it doesn't mean that what you're doing is bad or inherently unuseful. It's just that's just the way that things work as you start to broaden the scope of whatever your impact is.
I'd like to talk a bit about the connection between technology and burnout. And it's often tossed out as an assumption. And I think work like Gawande and others have highlighted that some people in some circumstances with some technologies get more burnout. Burnout understood as a very large category of emotional, psychological, physical effects. I think you've painted a bit of a model for how that happens, which is where the design of the technology is either old or malaligned or misused in some way that it doesn't help the efficiency of the provider. I could see voice dictation is a great example of something that just makes it easier to interface. We wrote a book, of course, with AMS Healthcare on compassion and technology. And some of what I've come to appreciate over time is that there are a lot of individual factors that are relevant here. Just think about a few of them. One is cognitive, actually. I often get asked the question about whether there's a generational effect, the famous millennials using computer games versus the older physicians. And I'm quite aware that there's a phenomenon when a new technology comes in that sometimes older physicians will take that as an opportunity to retire. There's a learning curve to adopting a new technology. But I think we can carry that too far. I think there's also the issue of young people. We should never assume that somebody, just because they're 20 or 30 and maybe video games existed when they were kids, that they would automatically somehow be adept at using an electronic patient record or interacting virtually. So I think there are individual factors, but there also are locational, cultural, geographic factors you've alluded to. I'm actually sitting right now recording this on the shores of a lake just north of Toronto, and this is one of our remote sites where I have the possibility of connecting through the internet in a way that I would not normally have. So I could argue that the ability to do this virtually with you in Alberta is a huge advantage of technology. And I'm guessing you've mentioned remote communities, indigenous communities. There are lots of folks in various locations who are going to benefit greatly because the technology is available to them at a distance. When we're close together, I have different questions about this, and maybe I'll get you to reflect on this. So I mentioned early on that we had a kind of a blanket decision in my hospital in wave one that we would just go virtual. So we have about 1 million outpatient visits a year, and pretty much overnight, we got the directive to start shifting to virtual. As a psychiatrist, I'd really done very little virtual consultation. I was involved in the Northern Ontario Psychiatric Outreach Program, so we did use the Ontario Telehealth Network for many years now to do some consults, but with a very special setup with someone at the distance site in the room, and the whole relationship built for safety and all of the complexities of billing and legislation and credentialing. But all of a sudden, overnight, I was talking to every one of my patients in their home, and their home could have been miles away, but it might have been just down the street. And all of a sudden, I found myself confronting the fact that I was not fully competent in the same way I was with face-to-face. I've said often, I know how to use the telephone. I've been practicing with the telephone for decades, and I can be compassionate and empathic on the telephone. Outside of some consults in the north through OTN, I had never done psychotherapy, for example, over the internet, virtually. So I'm interested, we've talked about the technology interface in burnout from the point of view about just being able to use it, whether it makes your life easier, whether the interface works or not. But I'm wondering about the empathy and compassion piece. I'm interested in your own work, what you think, if anything, the virtual connectivity with your patients does to your ability to be empathic, to be compassionate, and to make an authentic human connection with them.
So I think that those are really important questions for us to ask ourselves as we unpack this. And the reality is, in the course of the pandemic, we've been moving forward at such a fast pace that I don't think we've actually sat and reflected about the majority of these things. We've made decisions and we just assumed that they were the right ones because catastrophe didn't happen as a result. And I think particularly the question around our ability to be compassionate and to connect with our patients through virtual means is a really important one. We know that the majority of communication is nonverbal. I think persons who have a lot of deep experience with clinical settings, especially in your field, psychiatry, or my field, anesthesia. I mean, we have to figure out in a fairly rapid course of time whether or not we've established a trusting relationship with our patients, because that really is the core of everything. And I think technology makes that really hard. I found in talking with colleagues about adoption of technology in the pandemic, when we talk about telemedicine, what it more or less means is talking over the phone for the majority of people. And we have these new ways of communicating, including the way we're communicating right now over Zoom, that give us an opportunity to tap into some of those nonverbal cues. We're not used to eliciting those responses in the way that we would in person. I think it's tough for some people to wrap their heads around. And so you fall back to things like telephone consults because you've done it before, right? You can hear people's changes in voices, what the expectations are on both sides. I don't think we have been asking the question of whether or not we're connecting with our patients. Do patients enjoy not having to travel to the hospital? Especially in a community hospital like myself, where they have to travel sometimes 4 or 5 hours to get to Grand Prairie. Of course they enjoy not having to travel. Now, if that adversely impacts the preoperative assessment I do, which then leads to a more dangerous situation on the day of surgery, if I gave them, the value proposition of having optimization prior to coming for surgery and having a better outcome versus not having to drive 5 hours, I do wonder whether or not patients would still look at telemedicine the same way.
If your work bridges the gap between technology and compassionate care, you could benefit from AMS funding. Apply for one of 10 AMS Compassion and Technology Fellowships of up to $75,000 available now. Visit AMS Healthcare for more information. Also, if you find these conversations interesting, check out the AMS series, Without Compassion, There Is No Healthcare, on the Healthy Debate website, healthydebate.ca.
I have a fantastic picture of you. I should have asked your permission to use it, but it's on the internet. It's you with a child and you're making eye contact. It's a model of the doctor-patient relationship, of the direct connectivity. And I like to make the point that part of our ability to build a relationship with a patient is the hands-on and the touch. I know from both clinical work, but also being a patient, going to the operating room, the anesthesiologist's direct eye contact and maybe a touch as you go to the OR is, I'm pretty sure, associated with a better outcome, given the comfort you said. And even as a psychiatrist, although we don't physically touch patients a lot, I work in intensive care and places where I know that direct contact is really important. I think it's interesting you're saying that we haven't thought this through, and maybe as an indigenous physician, you could help me think through something about this, is that I know when I worked in Nunavut for about 10 years doing consults, it was explained to me that I really needed to work hard to understand when eye contact would even be appropriate. And that for some people that direct eye contact would feel like inappropriate touching. And I would learn, especially with elders, I learned to avert my eyes and to sit side by side and speak. There's an example of something where I'm totally at sea when I'm on Zoom or Teams talking to someone and I'm trying to decide if I'm making eye contact. Right now, I'm kind of looking at you, Alika, sort of, except really the camera is making me pretend that I'm looking at you. And I'm grappling with the fact whether this is therapeutic or not therapeutic, or whether it might even be weird in some circumstances. So I'm interested, given that I have this iconic photo of you with a young child, like with a child or an elderly person, for example, how are you thinking about trying to build empathy digitally or over video when you can't actually touch them?
Mm-hmm. I think when it comes to situations where this becomes more important, you kind of have two sets of patients, just in broad categories. You have those who are empowered, who, regardless of what you do, are going to be okay. Whether you make eye contact or not, they know how to navigate the system. They have confidence in their understanding of their chronic disease. They feel empowered in making the different choices among the options that you provide them. And then you have a class of patients who feel disempowered, either because they feel like they lack trust within the therapeutic relationship. Maybe they're confused about where exactly am I as far as diagnosis and treatment? What are the options available to me? They may not have access to the information that they need to develop these skills. And part of that is access, part of that is historical. Right? We all know trauma is something that patients bring into the therapeutic relationship, especially those who are indigenous. I think for those who feel disempowered, when working over video, you do have to provide certain cues to patients, and sometimes they have to be more explicit. When you're in a face-to-face therapeutic encounter, you know who else is in the room, you know how they're talking to each other. I don't know whether there's somebody off camera who, is poking the patient, trying to prod them to say something that maybe they don't really want to say, or telling them to stop saying things because they feel like the conversation is maybe going in a direction that they don't want. It's easier to assess that sort of thing in person. And so I've actually found with telemedicine, whether it's by phone or whether it's virtual through some sort of video conferencing, that taking a moment and just explicitly asking the things that you'd normally be able to pull out if you were there in person is something that actually goes a long way. And, really setting the stage, I think sometimes as clinicians, and I mean this generally for all encounters, we often assume that patients should be prepared in some way for the encounter. And I think that's a fair expectation if you've developed a relationship over many encounters. But especially when a patient is coming in contact with kind of you and your way of practicing for the first time, it's really important to set the stage. I think of video conferencing more like doing a keynote presentation. You're kind of bringing the audience into the way that you go about doing things. You outline the different steps. You tell people when they can interrupt, when they can't. And it's not to create some sort of rigid structure that they have to follow. It's just those are the cues that we have in person that we now lack. Yeah, because we're kind of connecting back and forth. And I mean, even in this interview, we're kind of getting a feel for the ebb and flow of when I'm talking, when you're talking. Yes. When in person, we just wouldn't we wouldn't question those things.
Yes. I walked out in the hall and I was at my office physically at Toronto General Hospital last week. And there's a confluence of 3 corridors and all of a sudden 4 people were together. I've not been in a corridor with 4 people for a year and a half. And we could not negotiate the physical distance and the who passes where and what it was. We were dancing. It was funny. I think you're making a really important point here that I've been reflecting on. And that is the provider helping together with the patient, not in a prescriptive way, but having a conversation about the setup, the context. An element of this that I've become aware of is the benefit and risk of being virtually in someone's home. So unlike, and this applies to the provider too. So unlike the past where we set the stage is my office, the patient comes into my office, I come into my office, we all decided what we were going to wear, and we follow a time-worn ritual of doctor and patient or healthcare professional and patient. All of a sudden, I'm looking into your home right now, and I see whatever you have on the wall or whatever you don't have on the wall. And although my neighbor took out the garbage last week and I noticed he was wearing a suit and tie from the waist up and Bermuda shorts and flip-flops from the waist down. So there are some nuances of what we actually show. We are curating our own space for how we want to project it. I think there could be some good things to that, but I'm going to give the analogy of social media here. So I see a fair number of young adults, teenagers, folks that have depression, anxiety. And forgive me for a slight tangent, but in social media, people curate their identity so heavily. I saw a young man that had depression. I was asking him about his social life and his friends. And did he have friends? And he told me he had 107 friends. And I said, yeah, well, that's Facebook, I'm guessing. Do you have any friends that you could actually sit down face to face and have a conversation with pre-pandemic? The answer was no. So I realized that he was a young guy trying to form an identity and anxious about who he was and spending an awful lot of time about what he was projecting on the internet and having very few opportunities to really interact with someone face to face. So if we bring that into this conversation and I think about what maybe my patients might be doing in terms of curating what they want me to see by arranging their home, by what they're wearing, thinking about this pressure of what they're showing, and aware that I'm doing the same. I have to think a little bit about what is it that's hanging behind me. I'm not showing my whole office. I'm showing one wall and what I'm wearing from the waist up. So it strikes me as all a little bit bizarre and fraught that we need to think about the environment we're creating. I've noticed recently a number of times my patients online apologizing for things. At the start of this, you closed the door because you said there was the sound of a dog. So, aha, Alika has a dog. And actually, sometimes I find it helpful to have the child walk through the screen or the partner poke their head in the door. But I'm aware that we are, I guess it risks being intrusive, but we are peering into the home of another person in a way that we never did when they came to the office.
Mm-hmm, mm-hmm. Yeah. I think that's a very valid point, and it adds another layer of vulnerability. I mean, some people when they communicate, they yell across the house. You know, if you're doing an engagement with a patient and you hear that, a family member's yelling, I can only imagine as the patient, you're kind of sitting back and going, well, what does my provider think of me now?
Yeah.
If they hear that this is how we're communicating, when it may just be practical because the sound doesn't carry. The other layer of that, I think I'd just like to bring in, and hopefully it's not too much of a tangent, is how virtual care or virtual use of meetings and other things has changed the way that we interact, just within the healthcare system itself. Virtual meetings have also brought us into the homes of each other. They've also made it very difficult for people to show up to meetings and provide no content or value. It's pretty clear if someone's on the meeting and they're just kind of lurking versus actually doing something. And I think the other thing that it's created is the ability to bring in persons who would normally be constrained by geography or time and actually have them be a part of decision making. And so that's changed the expectation for how things actually work. Having these COVID updates with hundreds of physicians or thousands of physicians, depending on kind of where you're at, and being able to log in regularly on a night, if it's a regular type of meeting, and hear that leader talk about strategy is something that I don't think we ever had access to before this. You had to make your way to an auditorium, and if you were providing patient care, there was no ability for you to do that.
I think you're right about the democratic participation in media. If I think about meetings, I think of our medical advisory committee, for example, I believe that there is more broad-based input. I think folks that sat quietly at the scary boardroom table looking invisible before, there's something about the platform, about the Brady Bunch or the Hollywood Squares that fosters a little bit more of a chance to speak up, or at least as a chair, you can ask, you can invite more input. Mm-hmm. Mm-hmm. That may be a good thing. We're going to have to decide what we keep virtual and what we don't. There is another downside, though, which I've noticed. So a very senior leader in my organization called me the other day and she said, I'd really like to actually come to your office. It was the other day in wave 2. So we were still in a fairly strict lockdown. And when she got to my office, I realized she was struggling more than I appreciated. She expressed quite a lot of anxiety about and doubts about whether she was doing a good job as a leader. Now, she is a very good leader, and I thought she was doing an excellent job. But I realized that we've lost the hallway conversation. We've also lost that informal interaction, which has quite a bit of power, probably also in the patient consultation too. But that moment before you actually start to meet, I notice when you have a Zoom call or a Teams call or something, everyone's on time, which is remarkable, and everything ends on time, and most everybody speaks. But it's only most times to the business at hand. It's hard to get everybody to engage in something lighter. There's nothing worse than a Zoom party. I don't know if you've ever been to one, but I find them not fun at all. Let's take medical advisory committees just as an example. We all attend many committees, but do you think it would be good for these reasons we've talked about for doctors and health professionals to continue to have large meetings virtually across the country, save the airfare, not fly? Or is there an argument to be made that sometimes we need to be in person to build that informal relationship, to connect with each other? How do we find that balance, I wonder?
So I think there's one thing that is clear from telemedicine, that if you don't connect with your patient first and then subsequently connect by telemedicine, you actually don't end up forming the same type of relationship that you do otherwise. I think that's one of the reasons why I strongly recommend that if people are going to provide that interaction with patients, that they actually go visit the community first, and they spend a bit of time, maybe the first or second time you meet someone. And then after that, you've had the opportunity to connect in a way that you really can only do in person. I think the question about whether or not we should save the airfare and other things is one that we're going to really struggle with over the next few years. You're onboarding people into new committees, whatever the context is. You just don't get the chance to connect with people the same way because you don't have the opportunity to, move into a breakout room in Zoom unless you ask somebody, which ends up being an awkward ask sometimes. You could throw things into chat and you can send direct messages or other things, but even that lacks context and the other parts of the interaction that you can only really appreciate when you're kind of working with people in person. I personally think that the ideal mix will be one where in the early meetings, you connect if there's a specific time-sensitive decision-making reason to get together. I think those can be done very effectively over, Zoom or teleconference. Just like when you're going to have a water break or like lunch or whatever, you end up entering into these conversations that unpack problems and taking directions that you didn't anticipate, but really end up building relationships and help you to see things in a broader way as a member of committee. We've also lost that with patients when they're walking out the door and as they're grabbing onto the handle of the door, they ask the question they actually want to ask. Mm-hmm. When you're on a Zoom meeting, it's done. You press leave and the entire interaction is done. And I do agree with you that we don't actually have a good tech workflow that provides an environment where that can happen in a reliable way. And I think that is a big loss for meeting in person.
One of the things you said earlier, which I completely agree with, it is the lack of vetting of technology. We sort of just adopt systems. I think about a very simple technology, which is texting. I've often said that a text sent to a potentially suicidal patient that you know well saying, "Are you okay?" can be incredibly empathic, and it can of course, it has risks like any technology. It needs to be embedded in a relationship. It might be the most effective technology at the time. I think one of the things that we're struggling with is the technologies are coming fast and furious. Electronic medical records, virtual, digital, voice dictation, artificial intelligence, text, social media, they're raining down on all of us. I'll speak for myself only, but I didn't have any kind of technical background when I went to medical school. I actually predate the internet. That's how old I am now. I worry that the acquisition of these technologies doesn't always include patients and providers. You alluded to this earlier. How do we engage patients and families and partners into institutional decisions about which technologies we're adopting? You mentioned using remote technology to service a rural community, for example. That's probably being broadcast from a large central academic center like Edmonton or Calgary. What are the ways that how do we involve folks who live in those communities in terms of which technologies are acquired and which ones are most effective?
So I think that actually cuts to the core of a broader problem we've always had, which is who gets to make decisions. How do we bring people's lived experience into the way that we think about what we should do, and then how we filter through the different options that we have. And, the equity, diversity, inclusion, that's really the impetus for bringing people around the table. We've realized that without the lived experience of persons who aren't around the table, a lot of our strategies actually fail when we try and operationalize them.
Yeah.
And so I think technology, it both magnifies the good and the bad of the way that our systems currently work. And in the magnification of seeing that technology often doesn't include the people who are actually using the system sometimes, because your funders are often very different than the persons who actually implement what you choose. That problem's just been magnified. I think technology gives us the opportunity to make decisions in different ways. You and Affleck, who I think both of us know pretty well, and in his presentations, he always talks about the real promise of technology is to remove the time-based constraints of people needing to be connecting at the same time, and also the geographic constraints of people having to connect within the same place. I think that's been used in the past to close off the people that you could involve. And I think part of that was just the practicality of fitting, more than 20 people within a boardroom.
Yeah.
Right. That was impossible. But I don't think we've actually thought through the process of how within leadership we could include more people using the virtual space. We collect so much data using advances in technology. The tech company I work with, the projects that we do with safe space networks, we're using technology to provide a space to persons who normally wouldn't speak up about things, or who wouldn't speak up about certain things because they're afraid of what would happen to them as a result of being the person who kind of brought that issue to the table. That's not something you can actually even do within in-person decision-making spaces. And so technology in that sense can have a huge benefit to creating additional space. But then you have, meetings of thousands of people. Who's monitoring the chat? Who's monitoring the direct messages? Who's monitoring, what's going on in real time? Who do you give attention to when you have 1,000 participants and you only have an hour for your meeting? We really have to think through, again, the way that we collect data, process data, analyze it, and then validate it. That's an ongoing challenge that we've always had in health. But maybe for the first time, we've articulated exactly what we need to do. And it's just more and more clear to us every day, like how significant the exclusion actually is.
I think at the end of the day, the technology is inert. Technology itself doesn't have inherent morals or ethics or values. It's driven by those in whose hands it's operated. Your point about who's online, who's doing what's the purpose of it, what's it used for. I know you probably have another virtual call to go to right at the hour to be right on time, as we've commented on. I just would think maybe we can close the conversation just with the note that for all of us, physicians, all health professionals, looking forward, it's an extraordinary time. The paradigm shifted rapidly and quickly, and we haven't fully engaged our colleagues, patients, families to really help us figure out which technologies we should keep, which ones we should refine, and which ones we should maybe walk away from. But it's a great opportunity for us, for the health professions, to think about finding new efficiencies and new ways of relating, but we have to be really incredibly cautious about how we do it so that we derive maximum benefit for people, and not in an across the board one size fits all way, but to really pay attention to which groups are benefiting in which ways from the technology we've adopted.
Yeah, and I think just to add to that, more and more, I think of technology as an enabling tool for what we're doing already versus a replacement or solution to what our problems actually are. Mm-hmm. You know, an electronic medical record takes the process of what we do in our workflows and makes it easier for us to input data without having to grab papers, pens, go to different locations within the hospital, pull charts from different geographic locations, leaf through them. You know, everything becomes accessible in a more direct and quick way. Now, if you set it up that you're not actually accessing the information that you need, then the technology is not really useful.
Yeah.
And I think that's the question that we all need to struggle with. Healthcare systems that work because relationships exist. It has nothing to do with the technology, whether it's digital or analog, that we use to interact. And if technology weakens relationships, I have a general stance that it's probably not a good idea.
Yeah.
If it strengthens relationships, then I think we're on the right track. And nothing will ever be a catch-all solution. But like you said, there's a huge opportunity for us to do things in a better way, in a more person-centered way.
Alika, I really appreciate you taking the time and the chance to chat with you today. I'm very excited about you coming into your role in the Canadian Medical Association. It's always a pleasure to be with you and to talk with you and to learn from you. Thanks very much.
And thanks for making the space to participate in these kinds of conversations. I think real innovation happens when people have open conversations about kind of what's going on. And I've really enjoyed the chat, as always, Brian. So thanks for having me.
Thanks for joining us for our conversation building virtual relationships, and a big thank you to Doctors Alika Lafontaine and Brian Hodges. Don't forget to check out our technology and compassionate care funding opportunities. And please, join the conversation next time on Good Tech, Compassionate Healthcare.
This podcast was produced by Michael McDonnell, music by Carlo Cruz.